You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Well, good morning, everybody. This is Conferences Online in Allergy. It is August 29th, and this is the first of two talks today. Our first speaker is Dr. Princess Ogbogu. Did I do that right?
Yes, that's correct.
Okay, thank you. Dr. Ogbogu is Director of the Division of Pediatric Allergy, Immunology, and Rheumatology at University Hospitals Rainbow Babies and Children's Hospital in Cleveland. She earned her medical degree in Northeast Ohio Medical University, completed residency in internal medicine at the University Hospitals Cleveland, and her fellowship training was at NIH. Prior to joining UH, she served as Division Chief of A&I and Co-Training Program Director for the Fellowship Program at The Ohio State University. Dr. Ogbogu serves as Vice Chair of the American Board of A&I and is member of the ACGME Review Committee for the A&I and holds many leadership positions in several of our national committees, American Academy of Allergy and the American College. So with that, Dr. Ogbogu is here today to talk about disparities in allergy and asthma. So we thank you for being here.
Thank you. Thank you for inviting me. So please let me know if I need to speak a little louder. Hopefully you can hear me, and I'm glad you can see the slides now. So we're going to talk about cross-cultural communication, which involves disparities in allergy and immunology, but sort of how we as allergy immunology providers can help improve health equity in our patients that we care for. And please feel free to stop me along the way if you have any questions or comments on the topic. Here are my disclosures. And here is an outline. So the objectives here are to describe ways to approach low health literacy in clinical encounters, discuss how an individual's illness representation influences health outcomes, and then identify specific actions that healthcare providers can take to reduce healthcare disparities. So if you can just go to the learning objectives, then I'll just start from there. So the objectives for the talk are to describe ways to approach low health literacy in our clinical encounters, to discuss how an individual's illness representation can influence their health outcomes, and then to identify specific actions that we as healthcare providers can take to reduce disparities. Next slide. So many of you have likely seen this figure before, this graphic, and it's really the difference between equality and equity. And equality certainly is providing the same resources for everyone, while equity is taking into account the obstacles or differences that patients may have in order to achieve the same outcomes. And so in our healthcare, we're really trying to strive for equity rather than just equality, and acknowledging some of the factors that might prevent equity. Next slide. So this figure is from the Healthy People 2020 and Social Determinants of Health. Understanding health equity means understanding the social determinants of health in order to reduce disparities. And so there are various factors of social determinants of health that are important for us to know. And essentially, they are the conditions or the environments where a person lives, works, plays, worships, and they all affect the quality of life and they affect health outcomes. And so these areas are health and healthcare, so access to care, literacy, education, and that includes early childhood education all the way to higher education, neighborhood and built environment, so access to foods that support healthy eating patterns, crime and violence in the area, environmental conditions, housing. Economic stability would include employment, food insecurity, housing instability, and poverty. And then, of course, the social and community context, so really civic participation, discrimination, incarceration. So those things are the social determinants of health that really affect the health outcomes of our patients. Next slide. So this is a slide from the American Medical Association's strategic plan for health equity from 2021 to 2023. And this is important to look at because I think it really, it summarizes what we see with health disparities, what may cause disparities, and what the downstream effects are. So this is the healthcare framework. And so upstream segments of the health framework are really prevention oriented, and then downstream are really treatment oriented. And so we know that there's certain upstream factors that can affect a patient's access to healthcare or their health in general. So root cause inequities, and this is going to be sort of all of the isms and obios. So racism, classism, sexism, homophobia, xenophobia, etc. Are the systems of power. And then the structural drivers are essentially going to be businesses, government, schools, policies. Living conditions are the social drivers. So this has a lot to do with the social determinants of health that we talked about. So the physical environment, economic environment, service environment, and social environment. And then these all impact risk behaviors such as smoking or poor nutrition or low physical activity, drug use, that then impacts disease and injury, and then subsequently or ultimately impacts mortality. So this is the healthcare framework, and American Medical Association makes a case that if these are addressed upstream, it makes a big difference downstream. And this is sort of the framework that we can take in a smaller view for allergy immunology. Next slide. So in terms of communication, the key components of communication are communication when English is a second language, addressing limited health literacy, which we'll talk about, understanding non-biomedical views of health and wellness, which I think will be a newer concept for most of us. It was for me when starting to delve into this area. Considering ways that technology may leverage and may hinder communication, and then overcoming barriers to communication that also include nonverbal communication and implicit bias. Next slide. So English as a second language and limited health literacy. So health literacy is defined by the Department of Health and Human Services as the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. Health literacy is sort of a silent and hidden epidemic because we know that verbal fluency can actually mask literacy issues. There's this assumption that because some English is spoken, that the entire conversation is understood, which is not necessarily the case. It's more complex than understanding spoken language. It involves numeracy, involves listening, it involves speaking. It relies on having contextual cultural knowledge, which is really important. And then it also requires the ability to integrate complex concepts. Next slide. So who's affected by this? According to the National Adult Literacy Survey, up to half of American adults are actually below the learning levels for high school and actually have difficulty acting upon health information. In the US, 1 in 5 persons speaks a non-English language at home, Spanish being the most common, and 10% are considered linguistically isolated. We know that persons with low health literacy are more likely to live in poverty, also have poorer health outcomes and greater health expenditures. And impaired health literacy can also be seen among educated populations. And so this is something that I don't think we think of often, but it can result in distorted interpretations or denial of medical and public health messages. So it's not really only in non-educated populations or poorly educated populations. Next slide. Next slide. So we know that patients that have low health literacy have poor outcomes. So they're more likely to visit an emergency room, have more hospital stays, are less likely to follow treatment plans for various reasons, and have a higher mortality. Next slide. So ways that we can approach English as a second language and limited health literacy are assessing the problem and being aware of the problem. So some of the things that may raise your concern that there may be limited health literacy, so if your patient's a non-English speaker, of course, maybe poor educational levels, poor reading or writing skills, which you may or may not be able to ascertain right away, poor conceptual abilities. You may see this when you employ methods such as teach back, etc. Poor medical understanding, limited or no internet access, perhaps a patient who has transportation needs or absent or insecure jobs, poor mobility, housing instability, or mistrust just in general in healthcare recommendations. And so some simple things that we can do are having a welcoming body language, which actually goes a long way to establishing trust and rapport, using interpreters. And so not really relying on family members to be interpreters. And so this means utilizing live interpreters, video interpreters, phone interpreters, but a formal interpretation system. Simplifying the information that we give patients. So simplifying written action plans and also simplifying oral explanations. And then where possible, providing information in both the native language and in English. And then listening for these cues and needs. So once you hear a need or cue that a patient says, I couldn't go get that medication, I couldn't get my inhaler, I didn't have transportation, then connecting patients with support. So either educators, medical assistants, nurses, social workers, and then understanding the needs of your specific patient population to identify knowledge gaps and to build trust. Next slide. So this is a topic that I said may be a little newer to everyone, which is non-biomedical views of health and wellness. This is also known as illness representation. And it's really understanding an individual's beliefs about health and illness. And this may not be congruent with the healthcare provider's beliefs. And so this can lead to medical non-adherence. So it's key to understand culturally preferred treatments. For example, asthma may be viewed as acute and episodic and unpredictable, and the preference may be to treat episodes and not prevent symptoms, depending on the patient's background and their illness representation. If you can go to the next slide. This is called the common sense model of self-regulation or shared regulation. And this is a model that's used by people who study illness representation. And essentially it's how an individual perceives and interprets their prior experiences. And so that leads to how they may address a problem. So they construct a mental representation of the illness, the threat of the illness, their beliefs about the illness, what caused the illness, what will fix the illness, what the potential consequences of the illness are, and then what the treatment plans are and how they appraise it all together. And so understanding a patient or a parent's illness representation is really key to being able to come to a common ground on how to manage a disease. Next slide. So the risks of illness representation are that it can really contribute to intentional non-adherence. And so this term really means when an individual makes a conscious decision to discontinue or to omit or to alter the prescribed treatment regimen. This happens all the time. I'm sure this happens with your patients. This is very common. Up to 50% of patients that have chronic conditions, and we manage chronic conditions, take medications as prescribed, and many want to be medication-free, so this may play a role. So half of our patients may do this, and this is really an important concept to understand. And then there's also the added layer of use of ethnomedical therapies without the provider being aware. And this can be, for example, traditional Chinese medicine or various herbal aspirations. So really being aware of where the patient is coming from and how they view the disease is really important in coming to a common ground on how to manage it. Next slide. So this table shows from a study in the American and Annals of Family Medicine, excuse me, that shows types of ethnomedical treatments cited by respondents of the survey. And as you can imagine, lots of herbal therapies, so for asthma, so ingested or topical, and also behavioral strategies, which you can imagine. And some of them may make a lot of sense to us, like avoiding smokers or getting rid of birds, for example, if that's the thing, or eating well or exercising. But then there are others. So many people may believe dressing warmly may prevent an asthma exacerbation. And so really understanding where the patient is coming from and what some of their beliefs are is extremely helpful in coming up with a plan. And then I thought this was interesting. If you just look for natural asthma remedies, which I think is a pretty highly searched topic, I found this from healthology.com that suggests ginger and honey and garlic and peppermint and lemon and turmeric and figs can help with asthma attacks or bronchodilation. And so, patients may be trying other things. So it's not that they don't want to be well, but may think that there are other treatments that may be more effective or less harmful than what you are recommending. And so this is why it's important to understand where they're coming from. Next slide. So how do we address illness representation? And so Tim Archileo, who has published some work with us in the Journal of Allergy and Clinical Immunology, and is an expert in this area, has provided us with a framework of some of the questions that we can talk about or we can ask. So one is asking a patient really simply, what do you think caused this? And what do you think this problem causes? So if you use asthma, well, what problems do you think that asthma may cause? How severe do you think this is? Sometimes this is very non-congruent with how severe we think it is. Do they think it's going to be something that's a long course or chronic, or do they think it's short and they can treat it and it will go away? What kind of treatment they feel is necessary? Next slide. What are the most important results that they're hoping to receive? So is it to be able to get through, school activities or sports, or sleep through the night without having to get up and use their inhaler? What are they hoping to achieve? Are there other treatment strategies that they're using? So this is where you may understand that there may be some ethnomedical therapies that are being used. What do they fear most about it, and what things make it difficult for them to manage this condition? So even asking some of these simple questions at the start, especially when prescribing a new treatment regimen or talking about disease management in general, can be extremely helpful. Next slide. So technology is also important for communication. And so we all know that we had a really rapid need to employ technology during the COVID-19 pandemic. We still do. So this included virtual appointments, communication through the electronic health record, mobile healthcare apps and devices, and monitoring. But what we soon realized is that not all patients really have equal access and or proficiency, which is really important with the technology. So, so that sort of increased what we call the digital divide for a lot of patients. Next slide. So the digital divide is defined as the growing gap between the underprivileged members of society, especially poor, rural, elderly, and handicapped portions of the population that do not have adequate access to computers or the internet. There was a 2019 American Communication Survey of over 100 million households that found that 32% didn't have a desktop or a laptop, 21% were without a smartphone that had a data plan. So we assume just because you have a phone that you'll be able to connect to your virtual visit and do all of the things that you need to do virtually, but not everybody has access to consistent data plans, etc. And then 14% were without any digital access at all, and this was more likely to occur in rural households and Black, Latinx, and Native American households. Next slide. There's also a digital divide based on age that can further exacerbate health disparities. And so this was a study published in 2016 that looked at adults that were between the ages of 65 and 79. And they found that the adults that were greater than 70 years of age were less likely to even be registered to use an electronic health portal. And then when you took the patients that were Latinx, Black, or Filipino that were between 65 and 79, they were less likely to use the portal and they were less likely to own a device. And then furthermore, if you took the patients who were Latinx, Black, or Filipino, greater than 75 years of age, they were less likely to even use internet or email compared to non-Latinx whites and Chinese patients. And so we have to think about these things when we are just saying, we'll just log into the portal or I'll send your results through my chart, however you do it, that there are many segments of our population that are isolated in this way as well. Next slide. So what can we do to bridge this divide? So locally, if a patient can access technology, we can bridge with really short explanatory videos, even in native languages, to talk about what we want them to learn about asthma or rhinitis or food allergy, etc. I think it's helpful to appoint a point person for technology in your practice that can ensure that patients who don't have access to EMR technology that do have this access know how to use it. And then to have flags in the system to identify patients who are going to need written communication or oral communication on labs because they can't access the EMR or they just have they prefer alternate communication. Next slide. This study was published in the New England Journal of Medicine, and this was interesting. There's really opportunities broader than for healthcare organizations to increase digital inclusion through infrastructure initiatives. And so it's understanding which patients even had access in your area to broadband, developing workflows that help with digital inclusion, so screening for social determinants of health. Some of our health systems do this, but maybe not as broadly as we need to. Understanding what digital discrimination is, and so being able to treat digital inclusion as a social determinant of health, because we know that it's really difficult to be able to process all the information that we provide patients without having internet capabilities, and then evaluating infrastructure and parenting or partnering with community organizations to help with teaching and training, etc. So there are things that we can do individually, but there are also things we can do as a system. Next slide. So another aspect of communication is nonverbal communication, which is extremely important, and implicit bias. I want to credit Dr. Benjamin Reese for this slide, who's done a lot of work in implicit bias and health disparities in general. And so this was published in the Journal of Pain and Symptom Management. And this was a study not that long ago. It was in 2016 of 33 hospital-based attending emergency medical or ER physicians, hospitalists, and intensivists from Allegheny County, Pennsylvania, the Pittsburgh area, that were put into simulations where actors portrayed either dying white patients or dying Black patients accompanied by a family member. And then the physicians were scored on the point system for both their nonverbal and their verbal communication skills when they were interacting with the family members. And physicians averaged about 7% lower scores for their nonverbal interactions with the Black patients than the white patients. And then, as you can see in the picture, with the white patients, the physicians were more likely to stand right at the patient's bedside and touch them in a sympathetic way versus, as you can see in the picture on the right, there's quite a distance between the healthcare providers and the patient and the family. Next slide. So So this is implicit bias, and so what is it? So this refers to the unconscious, and again, it's unconscious. It's not something that people do with knowing it. The unconscious mental process that stimulates negative attitudes about people outside of one's own in-group. And there's been extensive research into implicit bias, and it really supports the notion that we all hold unconscious beliefs about various social and identity groups. And these biases stem from our tendency to organize social worlds by categorizing, and they're also influenced by power dynamics in society. Next slide. So how does this impact healthcare? What does this do for us? And so a study in the American Journal of Public Health noted that physicians that were higher in implicit bias were more likely to dominate conversations with Black patients than those that were lower in implicit bias, and that Black patients trusted them less and had less confidence in them, and also rated the quality of care as being poorer. And then in the study in the Journal of Clinical Oncology of Black cancer patients, it found that providers that were high in implicit bias were less supportive of and spent less time with their patients than those that were low in implicit bias. These patients had more difficulty remembering what their physicians told them. They had less confidence in their treatment plans and thought it would be more difficult to follow recommendations. Next slide. So how do we overcome this? So there's an implicit association test that I think probably all of you have heard of. It measures attitudes and beliefs that people may be unwilling to or unable to report. It's online for anyone who's interested in taking a look at it. And then there are also recommendations by the Joint Commission. And so these are pretty simple. Having a basic understanding of the cultures from which your patients come. And that's really unique to each area where the patients come from, avoiding stereotyping and really individuating your patients, understanding and respecting the magnitude of unconscious bias, because again, we all have them, and then recognizing situations that may magnify stereotyping and bias. And formal training in implicit bias mitigation, which many hospital systems have, has been shown to reduce the impact of implicit biases in one-on-one interactions. So it's important to recognize it, identify it, and then figure out how best to mitigate it for each of us. Next slide. So the Department of Health and Human Services Office of Minority Health has a program called Think Cultural Health. And there are a lot of resources there that I found that we all can log into, and they're free, they're easy, but combating implicit biases and stereotypes are one of them, communication styles, effective cross-cultural communication skills, understanding different social identities, etc. So this is a really helpful resource that is available to us all. Next slide. So putting it all together, so communication is truly multifaceted. It involves literacy, language, illness representation, access to technology, and understanding our own implicit biases. It requires understanding the structural reasons that contribute to disparities and communication gaps. And then for us to know that non-adherence or non-compliance involves often more than a patient just not wanting to do it or just not being compliant, but there's more to it, especially as we delve into ideas like illness representation and what the patient's really thinking about that disorder. The problem with all of this, though, is that we all know that our provider encounters are short and communication takes time. Next slide. So ways that we can really attack this are being prepared. So I say prepare, prepare, prepare. Know your demographic, know the patient population around us, understand the cultural nuances of that patient population. And it will be unique for each city, and after training, it'll be unique for the city that you may work in. It might have been very different from where you trained. Create learning materials and action plans that can help. So these can be visual, these can be a native language, but these can be really helpful for the patient. And then provide trainee and staff education on best practices. So finding these opportunities for quality improvements. Identifying institutional resources and having these contacts readily available, because it's really, really difficult in the middle of a packed clinic to figure out who the social worker is for this clinic or the patient, or how to help someone who can't afford their medications and who we might be able to reach out to. And so it's important to prepare and have these resources and these contacts really at your fingertips, so that they can be provided in a really timely fashion. And then doing implicit bias training, I think this is good for everybody, because we all have implicit biases, and it's really critical to recognize and be able to manage these biases. And I believe most hospital systems now may even mandate some sort of training. And so, look into what resources you have for those, and consider just taking that test to see what implicit biases you may have. Next slide. And then identifying a communication ambassador. I think this is probably really key. This could be a non-physician member of your team that can screen for literacy, that can help facilitate interpreters, that can follow up on understanding. So this may be one of your nurses or your MAs or someone who's working on your team that can direct towards these local resources. So the ones that you have already accumulated and have at the ready, so that you can help provide these to patients. So this really takes teamwork, but having someone in your group or in your clinic that is the go-to person that can help streamline some of these things can be really effective way of preparation and helping the patients. And then using shared decision-making to build trust and to enhance communication. Obviously, when there's a lot of medical mistrust and different messaging, it's really important to understand where the patient's coming from, and then identify and together where you're going with the management and what the goals are together. And then really important to become locally active on issues that matter in your particular practice. And so there are advocacy groups, of course, within our professional organizations with the Quad AI and the college. And just to call to your attention, the Quad AI Committee on the Underserved, it's been changed now, the name, to the Diversity, Equity, and Inclusion Committee, to better capture some of the needs of our patient population, and to do it in a broad way that can impact our entire professional organization. So with that, I think that is it. Next slide. I will take any questions if anyone has questions or particular situations that they wanted to share or ask about. And Melissa, thank you for driving those slides.
You're welcome, and thank you for that great summary. I think it's always good to hear and cover those areas, and especially, patients aren't necessarily intentionally not following our treatment plans, or even if they are, they may have their own reasons, their own understandings of why they're doing it. So always great points to think about. Does anybody in the audience have any questions?
Okay, it sounds like no questions. Well, I hope it was helpful. Thank you for inviting me to speak on this topic.
Yes, thank you for being here, and we will get this uploaded to YouTube shortly in the future. Thank you.
Okay. All right. Thank you. Have a great day, everyone.